Very much. So then let's thank Dr. Wong for his presentation once more. Our next speaker that is on the program is not in. This was supposed to be a talk given by Dr. Tavakol, but Dr. Holme has kindly agreed to replace him. I have a clue about what she will be talking, but I'd leave it up to her to introduce herself and her talk. Thank you very much.
Thanks very much for this this nice introduction. So yeah, I'm Margaret Holme. I'm in Bert Muller's group at the University of Basel. I'm a postdoc there just now, and I'm going to be talking about the shear stress sensitive nano-containers that we're working on in our cardiology project, so treating cardiovascular diseases. So we've heard quite a lot about cardiovascular diseases already, but the salient points for treating it are that it's an impairment of blood flow through the vascular system. It's the biggest cause of death and disease in the world at the moment. About almost 50% of all the deaths in the Western world are due to cardiovascular diseases. And then on top of that, we have the additional problem that between 25 and 50% of patients who suffer such acute cases of cardiovascular disease like heart attack don't make it to the hospital alive. So there's a huge need for treating these diseases, and one of the main things that's used to treat the diseases in the ambulatory setting anyway is nitroglycerin, which is a vasodilator. And what this means is that in the case of acute heart attack, when you have a blood vessel in the heart that's blocked, nitroglycerin is able to open up the blood vessel and allow blood perfusion in the heart again. This is really, really important, because if you can imagine, if this is a heart, my hand, you've got your coronary artery here. If you have it blocked up at the top, there's this whole area of the heart down here that's not getting oxygenated blood. And what this means is that for the period where the artery is occluded, you have necrosis of the tissue after several minutes taking place, because the muscle is starved of oxygen. Nitroglycerin is good at opening up blood vessels and allowing this reperfusion, but it does have quite dramatic systemic side effects. Most importantly, you have to kind of keep giving more and more as you deliver the drug to the patient, because they start needing more and more to elucidate the same response as you'd get from a smaller dose when you start giving them the drug. And so these are the main problems with nitroglycerin, is just that when you give it, you have to keep giving more and more, and you get a decrease in the blood pressure in a systemic setting, and then you have this problem of eventually having to withdraw or severely limit the amount of nitroglycerin that you're giving to the patient, which leads to ineffective treatment at the heart. Now, the problem with treating, kind of targeted treating of the heart, is that although there are known biomarkers for atherosclerosis, there are no ones that are adequately prevalent that are specific to the acute case of heart attack. And so this is why we were thinking about using a completely different trigger for this drug delivery. We're using the physics-based trigger, so opposite end of the spectrum, and we were using shear stresses in the human vascular system. So what do I mean by this? Well, the shear stress is related to the velocity of the blood flow and also the thickness of the diameter of the artery. So the higher the velocity and the smaller the diameter of the artery, the higher the shear stress. And this is a really useful marker for us in the case of treating acute coronary syndrome, such as myocardial infarction, because when you look at the systemic arteries in the body, you see that they've got this shear stress of between about 0.5 and 1 Pascal. And then, go back. And then when you go to the coronary arteries in the heart, it's slightly higher. If you have a diseased coronary artery, it's about 10 times higher than it is in the systemic arteries. And then if you have a critically constricted artery, such as in the case of heart attack, you have more than 13 pascals of shear stress. And what we've actually seen in some of our modeling is this is more likely to be in the kind of 20 to 40 pascals region, specifically, locally to the constriction. So this is a really good physics-based trigger that we can hopefully utilize. And the project that we've been working on, funded by the Swiss National Science Foundation, uses just this idea. And we have our nanocarriers here that are sensitive to these shear stresses. So when it gets to the area of constriction, a drug is released, but only in the area of constriction, so we get rid of the systemic side effects. So this is basically the whole concept behind the project. Now, of course, the question is, you need to know what the shear stresses are in this critical constriction, and in order to do that, we've done quite a lot of imaging of critically constricted coronary arteries using computed tomography. So you can see here we've got our X-ray beam. This is our sample embedded in paraffin, and we take a series of X-rays, we rotate it around, and then we reconstruct them into a 3D image. And when we do that, we can get very nice pictures of, you can see here, this is the area of coronary artery with a bifurcation. And you can see the blue bit here is all of the stuff that's still available for blood flow. When we move on to this one, the grey area outside is the diameter of the artery, the outer wall. And all of the stuff in between is constricted. And then if we take a cross-section here, we can see that it's about 85% constricted by cross-sectional area at this point here. And we actually used this model for some simulations, and what we saw was that, no, it's not going to work, was that at this point here where it's critically constricted, the red colour here corresponds to about 17 pascals, and we have between about 2 and 4 pascals in the rest of this. Still constricted, but more healthy, more healthy artery than down here where the critical constriction is. And interestingly as well, we really didn't see much really high increase in shear stress around the bifurcation, which is reported in the literature that when you have bifurcations, you have a higher shear stress. So this is dealing with the kind of the physical shape of the artery, but it's really important to understand what the tissue characteristics are of these occlusions as well, because whether or not a plaque is vulnerable to rupture and myocardial infarction depends a lot on what the tissue's like, how thick the fibrous cap is. And in order to do this, we weren't able to get good enough results with absorption-based tomography because we don't see a good enough distinction between the soft and hard tissues. But if we add in a grating setup using phase contrast-based tomography, which not only measures the change in the absorption of the X-ray, but also the phase shift of the X-ray, we were able to see quite clearly a distinction between the fatty tissues and the smooth muscle and the plaque. So here on the left, what we see is the same artery that I showed earlier, imaged with absorption contrast tomography. And then the histogram of the grey values here, we see region 1 corresponds to all of the paraffin embedding material, and inside the lumen, and region 2 basically corresponds to everything that makes up the artery. And we can't really extract this data. If we look at the phase contrast image on the right, however, what we can see quite clearly if we add some color to it is that, so 1 here, we have all of the black around here, and also the stuff in between the adventitia here. And then the second peak here corresponds to the adventitia and also the foamy cells within the plaque. And then if we look at region 3 here, we can see the smooth muscle cells. And then if we look at region 4, we can see the area where there's been plaque. This sample has been partially decalcified, which is why there's nothing in the middle here. But we can see that this is where the plaque is. And if we correspond this to the histology, we can see quite clearly, just by looking under the microscope, that here, indeed, this is the region where there are foamy cells and cholesterol. And then here, this is where the necrotic calcified plaque was. And we can quite clearly, just by looking at the histogram of this phase contrast image, identify these areas using tomography as well. Now, the huge advantage of this is that we get a 3D picture of what's going on. It's very hard to get the same information out of a series of 2D histology slices. So here we are again, we can see quite clearly. This is an artifact caused by an air bubble in the sample. And then here we can see this is the area that's available for blood flow still. So in order to treat our critically constricted vessels, now that we understand them a bit better, we were working with phospholipid vesicles, liposomes. Now, if you look at a normal phospholipid, this is POPC, we see that it has got 2 tails, and then it's got a glycerol backbone and a head group. This is a phosphatidylcholine head group here. And what we did in the lab of Andreas Sumbuhl in Freiburg was to synthesize some non-natural phospholipids that have some rather particular properties that are useful to us in this setting. So the main thing to focus on is the backbone. Here we can see the glycerol backbone quite clearly, 1, 2, 3, and you've got the tail on the first and the second, and then on the third you've got the head group. If we look here, we've got 1, there's a tail, 2, there's the head group, and 3, there's the second tail. So the order of the tails and head groups is different. And what this means is that the tails are more spaced out, and so what we think is happening here is that they're interdigitated kind of like this. So that it's more rigid in that sense. And then also what you'll notice is that we've replaced the oxygen here, the ester group, with a nitrogen. So we've got amide linkers here, and we've got the possibility for hydrogen bonding across the membrane bilayer. And this also makes the vesicles more rigid. And what happens when we actually formulate large unilamellar vesicles from these is we see that they form these lentil shapes. And they've got these discontinuities here at the sides, which we're hypothesizing are kind of fracture points where the membrane bilayer packing has been disrupted, and we can have some release of drug cargo. And sure enough, this is what we saw in vitro experiments. So this is just using a commercially available mix of phospholipids taken from egg albumin. And what we see here is that if we pass our normal phospholipids through this pump system that mimics healthy here on the right and unhealthy on the left coronary artery, when we pass it round and we collect after one pass, we see there's no difference in the release of a fluorescent cargo. If we do the same with these PAD-PC-PAD artificial phospholipids, we see that quite clearly after one pass, there is some release in the healthy model because there still is a relatively high shear stress compared to the rest of the body. But when we have the critically constricted, we get twice as much release going from the control, twice as much release here as we have for the healthy one. And this was quite an interesting finding for us. It's quite clear that these vesicles are sensitive to the increased shear stress. However, you'll see that this is the distance between this kind of critical constriction here and the sample collection. It's about 5 centimeters. So we're not actually measuring what the fluorescence release is at the point of the trigger. And this is what we're going to move on to at the moment. We've got a PhD student, Marcia Busquema, who's working on these just now. And she's developing microfluidics devices that we're able to stick under a fluorescent microscope and also under X-ray scattering, small angle X-ray scattering, to have a look at what's actually going on at these critical constrictions. And she's been designing these microfluidics devices herself. So we'll get an idea about whether it's releasing exactly at the point where we need it to. Finally, of course, this is all very well and good. What's going on here? All very well and good, but this is all talking about our experiments that we've done using a laboratory model, using plastic arteries, using buffer, PBS and Hebrews buffer. It doesn't really bear much correspondence to what might happen when we put them in the body. And so we've been looking also at the body's response to these vesicles. And this is, I don't know if many of you saw Janos Sebny's presentation yesterday when he was talking about the Karpa effect, but we've been working, Simon, who's here, has been working with him doing some of the experiments to understand what the effects are in vivo. And first of all, using this in vitro Karpa experiment, what we were able to see was that after 45 minutes, if we look at the control here with serum and also just a isotonic solution of salt injected, we see a slight increase compared to the zero. But with the liposomes after 45 minutes, we're up at about 6 micrograms per mil response compared to 2 for the healthy samples. Now, if we take this compared to the control sample, we see at the control sample, we've got about 175 micrograms per mil. So actually, the percentage increase in the complement activation when we add these liposomes is very, very small. Now, we also put these liposomes into pigs and had a look at what happened there. And we measured quite a lot of different, we measured the bilirubin and the urea and the red and white blood cell count, and we found that they were all within normal values. But one thing that is interesting to note is that if we take here these pad vesicles that have a tendency to aggregate in solution, and if we take the aggregates and we inject them into pig, what we see is that there's a slight increase here, slight tendency to increase on a first injection of pad. And here we're looking at the increase of the pressure in the pulmonary arteries, which is symptomatic of thromboxane, which is one of the products that's activated by the CARPA reaction. So if we see an increase in blood pressure here, we're looking for an increase in CARPA activation. So what we see here is that there's a slight increase, and then on the second injection, there is a statistically significant increase in the pulmonary artery pressure. However, it's a relatively small increase compared to when we do the positive control. It's, we're looking at about 40%. So this is with the aggregates. This is maybe not so surprising. And when we actually remove the aggregates, we just filter the solution so that we get rid of the aggregates. We see that this effect disappears. So it looks like having the aggregates might be a problem. But when we remove them, we see that actually it's all within normal values and there's no statistically significant increase in the pulmonary artery pressure. So just to summarize, throughout the project, we find that the shear stress-based targeted drug delivery it seems to have quite good promise in the clinic. We've seen that the preliminary studies that we've done so far have shown the good in vitro results, and then when we move into animal models, they're not having any nasty side effects. The vesicle formulations that we've been working with do need some optimization, but we're getting there. The CARPA response is very low in pigs, which is good news, and we still need to understand the exact morphology of the critically constricted arteries to be able to model all of this release mechanism, so that we know exactly what shear stress range we're targeting, basically. So quite a lot of people to thank. The NRP62 has been our main sponsor, and then we've been a collaboration between Basel and Freiburg and Geneva, and these are the synchrotrons where we carried out our X-ray analysis as well. So that's it. Thank you very much for your attention.
Thank you very much. Very nice presentation. Are there any questions from the audience? No? Yes?
This shear stress-induced release of the drug from the liposome, may it be expected to be triggered by the chronic situation of an atherosclerotic plaque, or may it also be expected to be triggered by an acute spastic situation in the coronary artery?
Yeah, that's a good point. I mean, it depends very much on how we actually design the vesicles ourselves. A lot of the ones that we've been working on just now seem to be targeted slightly by the chronic one. I mean, the model that we were using has shear stresses of the healthy model has shear stresses that are found in the aorta. So you would expect even that in a healthy heart you might see some release. This is why we still need to work on the vesicle formulation. It's a difficult one to balance as well, because on the one hand you need something that's released in the acute case, but then on the other hand it's difficult to predict whether in vivo it actually is still useful to have it released in a chronic atherosclerotic plaque in the heart, for example. It gives you a bigger chance of a bigger release in the heart anyway, as long as it's not systemic release.
Okay, if there are no more questions, let's